All right. Hi, everybody. Gosh, my hair looks terrible. So sorry. Let's go on to mini number 2, which is the femur anatomy and positioning. Let's play the slideshow. All right. So we've talked a little bit about the femur. It's the longest bone in the body and the strongest bone in the body. What we need to be aware of when we have the femur is we have an angle of the neck here. You see this and this. That's where those two intersect. So when we get up to the hip, that's why it's going to be important to know where your central ray is going through so that you can put the plate in the right position. So the technical factors for this is shooting at 40 inches. You're going to have a KVP range of about 75 to 85. So we're going to align the femur to the middle of the IR. You rotate the leg internally about 5 degrees for a true AP. Now for the proximal femur, which is up here closest to the body, a 15 to 20 degree internal leg rotation is required, just like for the hip, okay? You got to ensure that the knee joint is included in the IR, so more than likely you will have to shoot 2 shots. And as long as you have the upper, then you know exactly where the lower needs to be. So this is very important. You have to include both joints. That's probably going to mean taking 2 x-rays, the top and the bottom. And that also is for both the AP and the lateral. So shooting a femur would be 4 separate images. All right. Now, if you happen to see a rod, you have to include the rod. Even if the rod goes all the way through the knee and down into the tib fib, you just keep taking it until you see the end. And that is both for AP and lateral. You have to see the end of the rod or screws or wherever it may be to get the end of that metal prosthesis. So the when you're taking the femur x-ray, you should have your tips of your toes pointed inwards. That aligns your greater trochanters to come out. And you should be aware that you're shooting through a thick portion at the top and a thinner portion at the bottom. That's why they're talking about the anode heel effect. Nobody really uses any compensating filters anymore, so it doesn't really matter. So here is a picture of a proximal femur, which is, yes, a hip. However, if you get the lower part of the femur, then you're going to have to go up and include the upper part of the femur. If you get the upper part of the femur, then you have to go all the way down and include the distal femur. This is what we mean by including the entire bone. So for the proximal femur, you must have the entire joint space, part of the pelvic brim, and to right about here where the pubic symphysis is. Because if you only include just a very tiny bit, you're not including all that needs to be seen on a proximal femur. So to do a projection for a lateral, you can either do it medial lateral or lateral medial. It doesn't matter, but we will do a trauma in just a moment, so don't worry about that. This would be for a walkie-talkie patient. You place the patient on their side and do not attempt this position if the patient has severe trauma. So when you place the patient on the side, you flex the knee approximately 45 degrees with the patient on the affected side, and then you can align the femur to the table. You place the unaffected leg behind that leg so that you prevent over-rotation. And let me show you a picture of this. Okay, when you put somebody's leg behind the other leg, they can push their hips forward and align their whole femur just nice and pretty. Plus, you can put something underneath the lower leg to bring it up and put everything into alignment. Otherwise, that leg is going to fall down and bring the femur over. So this is where you put the foot behind the femur, and this one is shooting a high, and this one is shooting a low. You can see the knee is included here, and this one the hip is included on that one, but it's not included on this one. So this one would need to go up, have 2 shots of the lateral. This one would also need 2 shots of the lateral because this knee is not seen on that X-ray. So we should have the femoral condyles will not be superimposed on this because of the divergent X-ray beam. It's not going to look like a knee because you are taking the central ray is right here. So whatever rays have hit this knee are already going at this angle, okay? That's not going to go through an open joint space anymore because we're not doing it directly right here. It's going to look a little elongated on this side. So here's what we need to see so this one is an upper lateral. Here's the mid shaft of the femur. Here's the ischial tuberosity right here. This is the acetabulum. This is where the hip bone is. So right here you can see the lesser trochanter, and remember that this patient is laying on his side. You are now seeing him lay on the greater trochanter. This part up here is the neck, and this is the femoral head. And I just said plus do a lower lateral, okay? We always got to remember to do both. So for a trauma lateral, do not move the leg, okay? What we do is we try to support the leg in any way possible so that we can get it up and put the IR plate behind it. Now, this can be accomplished by moving them to the side of the stretcher and having the plate move right underneath it, so that way you don't even have to push it. We can also do trauma laterals against the buckyboard. And I've been known to push it into the mattress because we couldn't get anything up underneath that patient enough. But essentially, you need about 3 to 4 inches of clearance on a foam or a pillow or something to get that up, even if you have to get something up underneath the butt of the patient to bring that up. Otherwise, your IR plate won't come down enough to get centered onto the IR, or to get centered onto it. Okay, and that is it.